Hi there, guys. Thank you for joining us this afternoon on today's webinar. We are focusing on improving training and education to deliver better healthcare for people with intellectual disability. This is Anna here, and I'm part of the National Centre of Excellence in the Intellectual Disabilities Health and Learning League. I will be the chair of today's webinar. We will begin today with some serious acknowledgement to country. As a member of the Learn League group, we respect the First Nations people and the elders from this land. First Nations people have lived on this land for a long time. Now we lived, work and play on this land together. We can learn so much from these people, from their stories and their knowledge. We will now play the video about the centre.
Hello and welcome to the National Centre of Excellence in Intellectual Disability Health.
We call it the Centre for short.
This centre makes sure people with intellectual disability get better health care.
At the centre, we talk to people with intellectual disability to find out what they think is important.
We talk to families and support people.
We work with health services and disability groups.
We bring information together from across Australia.
We share information about how to make good health services for people with intellectual disability.
We make sure there is health information for people with intellectual disability, families and supporters, health and disability workers.
We speak up on the big health issues and drive positive change.
There are 9 main groups in the centre. We call this the consortium. There are also more than 50 wonderful partnering and collaborating organisations. People with intellectual disability are a big part of the centre. People with intellectual disability work at the centre.
We're excited about improving the health and well-being of people with intellectual disability. Please join us.
To find out more information, go to our website nceidh.org.au and sign up for our news.
Welcome to the centre.
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 Yay!
I would like to introduce your speakers for today's webinar. We are now joined by Jade, the deliverer of the Ed Health, the director of the Ed Health, Jenna Zhao, a project manager from University of New South Wales, Tahi Hin, a project administrator at University of New South Wales, Sophie Howard, the lead of Driving Change at the centre, Laura Nain, the project worker for the Driving Change at the centre. I would like to pass on to you to get this started. To Jay, I hope you're on this camera right now. Enjoy your afternoon.
Thank you, Anna. It's a pleasure to be here today. I'm just trying to make the slides move, so okay. Lovely to be here with you all today and to see all those lovely faces welcoming you to the centre as well. I'm going to be talking about Sarah's story, and Sarah is one of my daughters who has had an intellectual disability, and I can remember being really shocked when I saw that people with intellectual disability died 27 years earlier than other people, and that 38% of those deaths are preventable, especially when I'm a health professional as well. So I'm also a registered nurse and credentialed diabetes educator and work with people with intellectual disability too. So Sarah, back in 2018, had what I would call a 12 seizure kind of day. Her disability was called Dravet syndrome, which meant that she had very unstable epilepsy and often would have multiple seizures in a day. By chance, I've got photos of Sarah during this hospitalisation because I used to take photos in order to make little social stories in order for Sarah to understand things. Now, on this day, she was living in her home in the community, and her support workers had called for the ambulance because she'd had a number of seizures. So they took her to accident and emergency, and once they decided she was stable, so she was okay again, they decided that she could go home. On the way home in the taxi, Sarah had another seizure, and so they turned around and went back to accident and emergency. So I'm going to talk about some of the things that happened during this hospital stay that highlight why we need to have health professionals better trained in how to provide quality and safe healthcare to someone like Sarah and all the other people with intellectual disability across Australia. One of the first things the doctor asked me when I got there was this question, what is Sarah's baseline? Now, first off, it's a funny kind of question because there's a lot of people who wouldn't know what that actually means, but they wanted to know what Sarah was like every day. And because Sarah had limited speech and lots of problems communicating with people, for a doctor to be able to decide what's happened from something like 12 seizures in a day, they need to know what the person was like before. And I have to say, this day, this doctor kept asking me, and it really hit me that I felt like he didn't know what to do if he didn't know what Sarah was like without having had the seizures. And it almost put him into a bit of gridlock. And once we could tell him what she was like, he seemed then to be able to go on and make an assessment. And I said to the doctor at the time, do you think if we had a video of what Sarah is like, normally, and we've got that with us, or we put it on My Health Record or something like that, would that make your job easier? And he agreed that it would. And it's one of the things I think we should be thinking about as parents or as support workers or disability organisations, that we start to get a video of someone with their approval of what they look like every day. There's also so Sarah ended up being admitted to the ward for observation and review, and here she is. She always slept on her big Ted like it was a big pillow, and I think it was like he was giving her a big hug. The sorts of things that happened during this 5 to 6 day admission, initially there were things like having to, we got our support workers there to support Sarah, but they were taken away at about day 4 or day 5 because NDIS had said that you're not allowed to do that anymore. So Sarah wasn't safe to be in hospital by herself. She couldn't protect herself. She couldn't give approval for anything. And she was very vulnerable if someone did something to her or tried to harm her in some other way. She was also in a single room, and having had a number of seizures and then trying to get out of bed, she could have had a fall and no one would have seen because she was in a single room. Being able to talk to the nurse, they said that they wouldn't put someone overnight to look after her to make sure she was safe. And so we were actually in a hospital where I'd worked previously. So I knew there was a nurse in charge that walked around the hospital. So I asked to speak to them. And once I spoke to them and said what we needed, it made a huge difference because they then put in someone at night as sitting outside her door to make sure she was safe, but she could still sleep. The support workers had been marvellous in being able to support her proactively. She knew them and she was familiar with them. They also could help her communicate, but also communicate back to the health professionals as well. Sarah had had bloods done and she had an IV that was started, and I always remember seeing the bloods from her discharge. There was an abnormal potassium level, and no one had mentioned it, no one followed up, and I'll explain why that was interesting later on. So there were lots of things we had to fight for in order to keep Sarah safe in hospital. I have to say, I'm a nurse and my husband's a doctor. We tried very hard to keep Sarah out of hospital. And even though we're health professionals, we didn't feel confident that they could look after Sarah safely because we'd been proven right so many times with so many things that happened. So there's Sarah. She went up to the ward. And then about day 5, Sarah was still looking really sad and grumpy. And I'd been coming and going and the support workers weren't there now. And once she was into a 4-bed bay, they had a nurse that was there overnight to look after the 4 people in the bay. And so she was getting better care than we thought might have been possible because of the way they adapted things. But she also wasn't eating or drinking, and I don't understand why they took out the drip. When I got there, she just looked really sad. And by actually putting myself in Sarah's shoes and listening to what she was saying, watching her body language, I thought, what would be the main thing that would stop someone eating or drinking? And I thought it would have to be something in the mouth. So I asked for someone to bring me a torch, which they did. And when I saw that her tongue, both sides of her mouth, were all mangled from the seizures she'd had. Now, this was day 5 after 12 seizures. Nobody had thought to look in her mouth. And so I wish I could have said to the doctor now, her baseline was that her tongue was fine because they didn't do what should have been a normal assessment. And I think partly it was because they were a bit rattled by all of this initial stuff, trying to work out what she was meant to be doing. When I saw that, I said to Sarah that it's okay, darling. Mummy's seed in your mouth. Mummy can see that you've got a really sore mouth and you've bitten your tongue. And Mummy's going to help the doctors to fix that. We're going to get something to stop it hurting, and we're going to help you to be able to eat and drink again with something in your mouth that will make it not hurt so much. And just by chance, I was mucking around with the camera with those filters that you can put on to show like little ears and a bunny nose. And one of the photos I took was this one on the right-hand side. That was Sarah's face after I'd said that to her. And you see the difference between the picture on the left and the picture on the right. And there was only about 5 or 10 minutes difference between those 2 photos. Now, I don't understand why she saw lots of health professionals and why they hadn't done some deeper thinking about why she wasn't eating or drinking. It's too easy for people to blame the disability or the lack of communication. And instead of doubling down and working harder, people disengage, I've noticed. They sort of stay away from that person. And especially if parents are there or support workers. But now that the NDIS are not letting support workers go in, Sarah couldn't have been safe for the first part. And clearly she wasn't safe because they couldn't work out what was wrong with her, which means I don't think they would have been able to prevent anything from happening as well. And we certainly heard in the Disability Royal Commission a lot of stories from parents like me about their family members not being safe in hospital. And as a health professional, that deeply worries me because it's something to do with the way we're training people or not training them properly, but we're also not engaging people to be empathic. If we get people to, at that moment of contact during the assessment, instead of asking me baseline, start doing the normal assessment, and then ideally we would have a video on My Health Record that would let them see what her normal was and then do the rest of the assessment. But it feels like things go into gridlock. Unfortunately, Sarah died 3 months after this hospitalisation, 2 days before her 26th birthday. She woke up in the morning, but then she was found dead in her bed. And I have to say, now I wonder, did that high potassium level make a difference in Sarah's death? It was never mentioned and it was never followed up, and that should have been followed up because as a mum, I'm left with lots of questions. If I think about some of the things that might have made a big difference in Sarah's experience, I think firstly it would be definitely training, but also much more emphasis around being able to use empathy. If we use empathy with someone, we're person-centered every single time. So engaging those skills we're talking about with people with intellectual disability ends up helping every person who comes through a health service, because that's all we all want is empathy. And maybe Sarah wouldn't have died quite so early, because she actually fits those statistics that I was saying before. If there had have been a disability-focused nurse, that would have made a big difference as well, because it wouldn't have been up to me to say what was needed. They would have been able to assess what they needed and make sure that they were there. There's no low literacy resources like I made for Sarah that you can see on the slide for her to remember what I've said to her. And they're often very easy to do, and they can have pictures put into them that would make it very easy. So I'm thrilled to be presenting and sharing Sarah's story. Sarah was a really loved part of our family, and she taught me a lot about life and love and being a good health professional. And it's almost like she's still here with me, being able to share this story with you, because we have to stop what happened to Sarah. And I really thank the National Centre for Excellence in Intellectual Disability Health for the work they're doing to progress this. So thank you. I'm going to hand over to Jenna Zhao.
Thank you, Jane, for sharing Sarah's story with us all. And I'm sorry about the experiences that you've had with the health system. My name is Jenna, and I'm part of the National Centres team that is based at UNSW. Today, I'm going to tell you about the Intellectual Disability Health Capability Framework, which I'll call the framework for short. We've just heard from Jane that many of the health professionals she has encountered were not prepared to provide care to Sarah and other people with intellectual disability. The framework is a document that says what health students should know and be able to do by the time they graduate in order to give good health care to people with intellectual disability. Unfortunately, my colleague Tali is sick today and unable to join us, but Tali and I helped to create the framework and some education resources to assist educators to use the framework. First, I'm going to show you a video about the framework to set the scene. Tali actually appears in the video, so you'll be able to meet her through watching it. Enjoy.
Hi, my name is Pali. I'm here to talk to you about the healthcare of people with intellectual disability. It can be hard for people with intellectual disability to get good healthcare. A lot of health professionals don't have the training and experience to understand and to adjust their practice to make it accessible. A lot of health students do not learn about intellectual disability at university. The framework will change this.
People with intellectual disability are a population group that experiences one of the biggest health disadvantages of any group of Australians. The Disability Royal Commission recently made a finding of systemic neglect in healthcare for people living with cognitive disability. The Intellectual Disability Health Capability Framework is one tool that will help future health professionals do a better job for this population.
I think as doctors of the future, we want to be that push for change, and we want to see those healthcare discrepancies that we see for people with intellectual disabilities minimised and, if possible, eliminated. But it's really difficult to be able to do that without having the practical skills and training that we need to communicate well with people with intellectual disabilities, their carers and their families. And I think actually having those skills is going to be really necessary for us to know how to combat these health discrepancies and actually create a positive change in the future.
The Disability Royal Commission has recommended action on this issue to ensure that our future healthcare professionals are better equipped. A key gap we've identified is for pre-registration curriculum content in the area of intellectual disability health. The Intellectual Disability Health Capability Framework sets out clear intellectual disability capacities and learning outcomes for students completing any pre-registration education program. We want accreditation authorities and education providers to integrate the framework into their standards and curricula to ensure that future doctors, nurses, allied health professionals, dentists, and health-related professions have direct exposure to people with intellectual disability and develop key skills to support improved health and well-being of people with intellectual disability.
When I get quality healthcare and feel supported, it makes me feel happy and confident, knowing I can voice my ideas and make my own healthcare decisions. I want quality healthcare to be the norm for all people with intellectual disability and everyone. I believe using the framework will help with this.
I hope you enjoyed that video and it gave you an idea about why the framework was important to create. Many university programs don't teach anything about intellectual disability, and it is time for change. The National Centre recently released its position statement on health workforce education and training. One of the recommendations from the position statement is that education about intellectual disability should be compulsory for health students. The framework can help universities to achieve that. I'll now tell you more about what the framework is and how it was made. The framework was made by the Australian Government Department of Health, Disability and Ageing, together with a group of researchers, educators, and health and accreditation experts from UNSW, Flinders University, Griffith University, the University of Melbourne, and the Australian Medical Council. Sorry, Tyler, can we just go back one slide? Thanks. As you may be aware, there is a national roadmap for improving the health of people with intellectual disability. The roadmap aims to address a serious health gap faced by people with intellectual disability. One of the priorities of the roadmap is the Intellectual Disability Health Curriculum Development Project, which is led by the Department of Health, Disability and Ageing. The Curriculum Development Project is about making sure that health students learn about intellectual disability when they're studying to become health workers. And one of the key parts of the Curriculum Development Project was to make the Intellectual Disability Health Capability Framework. The framework was released in April 2024 and has a list of 46 capabilities that all health students should have by the time they graduate and become health workers. Capabilities are things that students should know or be able to do. The framework also suggests learning outcomes for each of the 46 capabilities and gives information about how different people and groups can use the framework. Next slide, please. The framework was made through 4 stages of work. The first stage was a scoping and gap analysis that was done by the University of Queensland. The scoping and gap analysis looked at what university courses in Australia have content on intellectual disability health and what intellectual disability health learning modules and resources are available. The University of Queensland team also did some consultations to find out what people think is best practice when it comes to education and training about intellectual disability health. They then identified gaps by comparing the courses and content that they found to what people said was best practice. Using all of the information that the University of Queensland gave us, the framework team then did extra consultations with people with intellectual disability, family, carers and support network members, and health and education experts. We asked them what they thought health students and health workers should know and be able to do to give good health care to people with intellectual disability. We used this information and all the information from the scoping and gap analysis to write a list of capabilities. The list of capabilities was very long, and we needed to make sure that it was the right list. That was the next stage of making the framework. To help finalize the list, we did a Delphi research study. The Delphi study involved asking a group of health and education experts to do a series of surveys. Each survey asked them if they agreed that each of the capabilities should be on the list, why they agreed or disagreed with each capability being on the list, and whether there were any other capabilities that they thought should be included. Based on the survey answers, we changed the wording of some of the capabilities and added new ones before asking our experts to do another survey. After 4 rounds of surveys and changes, we had a list of 46 capabilities that all of our experts agreed were important to include on the list. The capabilities are grouped into 6 areas: intellectual disability awareness, communication, quality evidence-informed healthcare, coordination and collaboration, decision-making and consent, and responsible, safe, and ethical practice. There are 2 examples of capabilities here on the slide. One example from the area called intellectual disability awareness is practice in a manner that recognizes, respects, values, and includes the lived experience and lives of people with intellectual disability. Another example from the area called communication is communicate and engage directly with every person with intellectual disability, using their support networks to facilitate this when appropriate. After finalizing the capabilities, we then wrote some information about how to use the framework. We wrote learning outcomes for each capability. We also give specific information to accreditation authorities and educators about how to use the framework. Accreditation authorities are groups that make sure that all education programs meet a certain quality. To do this, they make standards which say exactly what students should learn in their university program. We also made 5 helpful tools for educators and accreditation authorities to use. For example, one of the tools can help educators to reflect on what knowledge and skills they have around intellectual disability health and whether they're equipped to teach students about intellectual disability. There's also a tool that can help programs reflect on whether they include people with lived experience in co-teaching. At the very end of the framework, a list of learning resources for students and educators is provided. To further help universities use the framework and add content about intellectual disability in their programs, we created new education resources. We wrote 6 case studies to give students an idea about what a person with intellectual disability may experience when they have a health problem. Each case study includes what students should learn from each scenario, discussion points, and other useful links. We turned 2 of these case studies into videos, and they were filmed with actors who have intellectual disability. One of the films is about communication and the other about decision-making and consent. The films start by showing poor practice and then show ways that health workers can improve their communication and use reasonable adjustments. Tali was involved in reviewing the scripts, watching the filming, and reviewing the final videos, which she said was one of the most fun parts of the project. We developed 2 lecture plans that educators can use. The first is an overall introduction to intellectual disability, and the second is on communication. The aim of the lecture plans is for educators to be able to take something that we've already prepared and easily add a lecture on intellectual disability into their course. We also made a lecture reference book, which gives educators more information about the content if they themselves don't feel confident teaching about intellectual disability health. We also made tutorial plans that go with the lectures. The tutorial plans include activities like discussion and analysis of the case study videos, simulation scenarios, and assessment questions. Another resource we made was the Co-Education Toolkit. The toolkit aims to support educators to find and collaborate with lived experience educators. It was developed through a process of interviews and focus groups with people with intellectual disability and carers and family members. We also did surveys with education experts and disability organisation representatives. The toolkit has information on the benefits of co-education, how to connect with and work with lived experience educators, examples of how a university might co-educate, and some helpful resources. Tali made an easy-read summary that outlines what is in the toolkit and how people with intellectual disability can use and promote the toolkit. Co-designing and delivering health education is one of the recommendations from the National Centre's position statement. Another one of the National Centre's recommendations is that health students should have more opportunities for placements or other practical learning experiences that allow direct contact with people with intellectual disability. One of the framework resources is an information sheet about how universities can work with disability organisations to create student placement opportunities. We encourage you all to use all of these education resources that have been co-designed with people with intellectual disability. You can also watch the case study videos and tell your health professionals about them. They're free for anybody to use. Please tell people about these resources and help spread the word to make health education better for students. Please also tell people about the framework. Even though the framework's been released for almost 2 years and there are many wonderful resources to help educators to add more intellectual disability health content in their courses, not everybody knows about the framework. It's important that we keep talking about it and telling people about it. We want accreditation authorities to read the framework and think about how they can include intellectual disability in their standards. The framework has some suggestions on how accreditation authorities can do this, and we also have specific advice for close to 20 health disciplines about how intellectual disability can be incorporated into their standards. If you're from an accreditation authority and want specific advice for your discipline, you can contact us or the Department of Health, Disability and Ageing. We call on health curriculum leaders and educators to include intellectual disability content in your programs, regardless of whether accreditation standards say you should. We have learning outcomes, assessment questions, and a range of very helpful education resources that can be used straight away to include some intellectual disability content in your programs. So I'll end with a message that Tali wanted to share. She says, "It is very important that students learn about intellectual disability. I hope this will change the future of healthcare for people like me." Thank you, and I'll now pass on to Laura and Sophie.
Hi everyone, I'm Laura Nang and I am a project worker on the Driving Change team. We do advocacy for the center and all its work. I want to improve health for people with intellectual disability. I love working with my colleagues and sharing my lived experience, enjoying meeting with important politicians like Mike Freelander, Holly Hughes, and Washington, and Mark Butler. Some fun facts about me are that I love taking my dog Simba for walks, and I love doing aquarobics. It's so much fun.
Thanks, Laura. And hi, I'm Sophie Howlett. I'm the lead for Driving Change, which is the center's advocacy work. And I work with Laura and the rest of our fantastic team, and we're all together pushing for better healthcare for people with intellectual disability. I wanted to start by asking Laura to share what we do in our advocacy work.
Well, I get to meet people who make decisions about health, and I get to share my stories. It is important to do this because sharing my story is a powerful way to get the message across. This is my experience. It helps people understand that this is real and that this goes on. I want to have my voice heard, and I will keep standing for better health for people with intellectual disability.
Thank you, Laura. You've done a lot of work to improve health for people with intellectual disability, haven't you?
Yes,
Well, I wonder if you could share a bit more about that work, the work you've done, particularly around developing health resources.
Yes, first, Sophie. I have done work on this include health education training. I co-developed the modules. This is really good training for health professionals. It gives you all the tips you need to better understand people with intellectual disability.
With Laura?
In this work, I also was a co-facilitator in workshops for health professionals in New South Wales and other states. We were trying to get the message out there about our training and about working with people with intellectual disability.
Yeah, that's so great. We've done other things to improve health for people with intellectual disability. Do you want to share a little about that?
Yes,
It's so busy.
yes, I've been very, very busy. I have also done work to co-develop the My Health Matters folder and My Health Conversation cards. These are important resources for people with intellectual disability. They make it easier to talk to the doctor and other professionals. I also want to say that I have given a core lecture to social work students about my work. The students gave me feedback and asked questions about my ex um uh about my experience with a social worker. I learned that you can have a social worker when you go to a hospital. I did not know that. And that student learned about my experience. It is so important to have people with intellectual disability given core lecture to student in university. It is such a great way to share experience and show what inclusion looks like. Sometimes a student have never had a person with an intellectual disability doing a lecture. We need to see more of this. And I want to do more of this too. When I give core lecture, I give the student tips about how to be inclusive. And they learn something new, and I did too.
That's so good. Thank you. Thank you for being out there, Laura, and sharing your story. You make it look so effortless. And it's really so important what you're doing.
It is, and yes, it's totally true. And when I did this work for the education modules, the feedback was so positive. People found the modules really clear and inclusive. People said this is so interesting and they had never heard this before. We really need this training. It's about helping each other. We're all educated. We can have a good conversation. We need to get more stories, more meetings with ministers and decision makers, and more people with intellectual disability giving lectures. It is important that health professionals listen to me and to other people with intellectual disability. With better awareness, we can make change happen.
Laura. And, we've already made some changes in our work at the center, haven't we? We've met with a lot of key decision makers, some of those you mentioned earlier. We are building relationships with other key decision makers. We have written a lot of submissions and we're getting our message out. And we hope today our people in the audience that you will help us in getting this message out. But I wanted to repeat Laura's point that we want to see more people with intellectual disability in the classrooms and, facilitating workshops, leading that inclusion. Because all health professionals will encounter a person with an intellectual disability in their professional lives, if not already in their own personal lives. So equipping health professionals with the skills to meet people's needs, whatever they look like, is the key challenge. And we're asking you all in our audience to rise to meet this challenge. So if you are, say, a health professional, can you do the Just Include Me training? Or learn more about how unconscious biases can impact how you might treat people with intellectual disability or your other patients. If you work for an accreditation authority or an academic institution, can you build the intellectual disability capability framework that Jenna spoke about into your curriculum for practitioners or students? And if you're, say, setting training curricula at a state government health department, can you mandate training on the health of people with intellectual disability or on unconscious bias? There are many ways to rise to this challenge of making health better for people with intellectual disability. Our point is that we all have a role to play. And as Laura says, with better awareness,
We can make change happen.
Thank you for all the speakers for your presentation this afternoon. We have now time for questions, given that we have limited capacity today. Please put your questions in the Q&A box right down below. The first question for Jane is, as a health worker yourself, did you get much training on the intellectual disability health? What gaps in training did you see?
I trained a very long time ago. I've been a nurse for over 40 years now. I felt very privileged because, yes, we did get training. I had a clinical attachment at a disability organisation, and that all came back to me after Sarah was diagnosed, and it certainly made a big difference. Having gone to, it was Minda Homes, it was called then, here in South Australia, and we got to see people in their school when they were swimming. We did swimming classes with them, but we also looked after them in the old style of accommodation. And I think the thing I thought the most after Sarah was born was, thank God there's been lots of changes in the fact you don't have to send your child somewhere to go to school anymore at 5 years of age. And so we were very, very lucky, but I don't think that happens anymore. So we not only got theory, but we also got to go and do a clinical practice.
The next question for Jenna. How can we make sure that the accreditation authorities use the plan?
I think it's first and foremost being aware of what they have in their standards and whether it encompasses providing healthcare for everybody in the population. And I think it's really critical that accreditation standards are changed to include mentions of intellectual disability to ensure that educators and university programs include that content in their teaching, because as we've heard from Jane, many professionals are really unprepared when it comes to providing care to people with intellectual disability. And that change needs to come first and foremost from accreditation, who say what university programs need to teach, and then university programs to include that content. But I think it's also important for university programs to include that content anyway, regardless of whether they're being asked to or not.
The next question is, to Sophie and Laura, how do we advocate for this change as healthcare workers and students?
I'll start while Laura's finding the mute button to say that I think leading by example is the best way to start this work if you're a health professional, to demonstrate inclusive practices in the way you work, and to try to seek information and learn all you can about how to give inclusive care. Laura, did you want to add anything?
Yes. Like I said, I want to help professional to do more like training so they can better understand people with intellectual disability and how to use easy way information. So so people with intellectual disability can understand and yes, understand the information.
For Jane, you spoke about some of the changes that you've ever seen over your career. What improvements have you seen since Sarah was in hospital?
None. I think it's actually gone backwards, I'm afraid. I think the NDIS has certainly increased understanding, but the NDIA's decision to not fund support workers to go into hospital with a person saying it's up to what they say is ridiculous, because they also say that the support worker should be able to train the health professional in how to understand their client and do the services. We know that the health professionals are understaffed. They don't have the skills, they don't have the knowledge. And then the one thing that did make a big difference to keep Sarah safe was taken away. I know that this is a really big sticking point. And to be frank, NDIA and the state-based health ministers just need to make a decision and get that funding back in for people when they're in hospital if they've got complex needs and very low communication things. They're not safe, full stop. People with an intellectual disability have human rights. We signed on to the human rights thing saying that we would do better for them with their health and give them good health. And that was back in, I think, 2008, and nothing has much been done. So it's about, for me, focusing on achieving the human rights of people with intellectual disability, like for any other citizen in Australia. And the Royal Commission, I did a presentation there, as did lots of people. You only have to go back and read through the stories from the health hearing. We don't have to keep proving it's a problem. It is a problem. And we have to get solutions. So some of those solutions come from funding for training, but some comes from individual health professionals just not being scared of people with an intellectual disability. Just treat them like anybody else. And, Sarah enriched our lives so much because she demystified disability for me as a health professional. And I really love that my daughter could teach me that, and her friends. So yes, it's just a matter of getting on and doing it and stop fighting between states and territories. And the NDIA has to listen to people. We need our support workers in hospital. It's not safe otherwise.
For everybody else, if there is one small change in education and training that you will see tomorrow, what will it be?
Me?
Yeah, if you're serious.
Yeah, no, I want to change the NDIA. I want to change the NDIA to see that people with a disability have health needs. And if you have something like diabetes, you need help to be able to do what someone without a disability can do on their own. That's the disability side of health. Whether they're in a hospital or where in a primary healthcare service, adaptation is required for that disability side of things. So there's my one big thing.
I'll go next. I want to see inclusive practice, and I want people to all take some responsibility for whoever there is in front of them, and inclusive care for everyone, whatever that looks like, is what I would like to see. Laura, what about you?
Well, I, I, well, I want to say, everyone to get a special, better treatment, looking after your teeth, dental care. I am, I am, making sure, like, asking the center open with that to make us to have some sort of like a professional and a know for like someone, because it's really important for everyone, not just intellectual, but everyone to get the access. Yes, so they don't have to pay out of their pocket. Wait.
Thanks, Laura. I guess for me, if we're talking about small changes that we could see happen tomorrow, I think a lot of what we talked about today could happen. So I, described a whole range of education resources that we made. They can be taken today and plopped into courses to be used tomorrow. Health professionals can do the Just Include Me training today or tomorrow, and that can affect change immediately, I think. So I think using the resources that we've talked about today, thinking about, I know that education providers, they often talk about the overcrowded curriculum, that students have too much to learn already. There's no space to also learn about intellectual disability health. I think with the resources that we've created, the case studies, they can be used, they can be used with the existing curriculum content. If you're doing something about diabetes, for example, you can still use one of our case studies that feature a person with intellectual disability. So I think these things could be used today to create change for tomorrow.
For Jenna, can you please talk a bit more about the education resources and how can they be best used?
Thanks, Anna. Yeah, so like I just said, they can be used alongside existing curriculum content. Even if you don't want to put anything that's specific to intellectual disability health in your curriculum, you can still use some of these education resources. The 6 case studies, you can, if you're looking for a case study video to put in your course, in your program, we've got 2 really great ones that feature actors with intellectual disability. They show, at the beginning what's a not so great experience and then what's a better experience, all in one video. So that can just be used straight away. We really like our co-education toolkit. Like Laura was talking about, being involved in training and having the opportunity to be in classrooms and to talk to students or other health professionals as part of their education and training. I think that's really important and definitely worth a look at, that co-education toolkit. And there's an easy read version that Talia created as well. So I encourage everybody to go and take a look, to think about how they can include people with intellectual disability in teaching. People with intellectual disability, feel free to look at the easy read version to have a think about how you might like to be involved and different avenues that you could take to make that happen.
So, are there any specific things that we are currently asking for the government to please do to improve the education and the training?
Yes, there's a lot of work we're doing in that space. We are currently working with a lot of the states and territories trying to have mandated training on intellectual disability health, or at least, like Jenna said, some kind of micro-credentialing where you take a case study and you build it into content that already exists that's mandated for people. We are working on, we submitted a funding bid to the federal budget to seek some CPD scholarships for GPs. As you know, primary care is the key, is the foundational entry point oftentimes into the health system. And so we need to be equipping all layers of the health system to meet the need. And so that's one avenue we're taking. And there's many, as Jenna's pointed out, working with accreditation authorities on the curricula and the standards. So we're trying to do all these things. We're kind of like an octopus with a whole bunch of arms out there, trying to make change from a whole, variety of approaches. I will also say, another of the angles that we're taking is with the hospital standards, the national standards that all hospitals are working towards. There's a review of those, so we submitted to that. And we're also working, I saw a comment in the chat about the activity-based funding that hospitals receive. We're also working with the Independent Hospitals and Pricing Authority. I always get their name wrong. We're working with them on looking at that activity-based funding to see if we can make an adjustment for people with intellectual disability. So yes, Anna, back to you.
I'd like to pass on to Jenna. For the next.
Thank you. So just the next steps for everybody who's watching today, we really encourage you to check out the capability framework and the education resources that I talked about. Please also check out Just Include Me that Sophie and Laura also talked about. Please subscribe to the National Centre of Excellence in Intellectual Disability Health newsletter, and the link is on the screen, and I think Tyler will probably put it in the chat. And please stay on Zoom to complete the post-webinar survey as well. And let us know what you thought of this webinar.